Hi everyone, my name is Renee. I'm a nurse by training. I've been with the Coalition for 7 years. The bulk of my time has been spent working with the community-based team of nurses and community health workers and social workers that are out there in the streets in the community working with some of the most medically and socially complex patients throughout the city of Camden, New Jersey. Vic and I have spent a lot of our career working side by side in this and really digging in and trying to figure out the craziness of complex care and systems and everything in between. Just to echo that we're really excited to be here to not only share our work in Camden, but also just to talk and learn from you guys as well. So thank you for having us.
And so a lot of our work is rooted in this slide right here. A slide that's probably very familiar to many in the room, healthcare paradox. And what it basically shows is disproportionate spending here in the United States compared with other developed countries in the world. And it really shows how we spend in healthcare versus our spend to social service without oftentimes the outcomes that we desire and want for people. And so, this is I think a common revelation now, but maybe, 5-10 years ago, it wasn't as common when we thought about healthcare. Even in our work in Camden, when we initially started, maybe 10 years ago, we were really like laser focused on the healthcare system. And in our heads, in our minds, and even as an organization, we thought simply if we were able to connect people who frequently use the ED, who frequently get inpatient stays, back to primary care, voila, it would all be answered, it would all be solved. Little do we know the problem was a little bit more deeper, a little bit more complex than what we originally thought. The patients that we work with, the patients that we see, not only engage healthcare, but they engage many systems, right? And so whether that's primary care, whether that's criminal justice, whether that's education, social service, behavioral health, mental health, there are a multitude of systems that our patients engage that we need to start to account for and better understand the relationship between. And so really, what we used then was data, right? And so at the Coalition, when we think about data, really we think about data at the population health level. And then we drill down to the most important piece of data, which is really at the patient level, right? That patient. And then how do you design an intervention? How do you design a model of care around the patient to best meet that individual's need? And so our programs vary. Our programs vary based on the challenges of the patients that we meet. Programs often vary based on the landscape of the environments that they're being built in. What is the community's capacity? What are the community resources? What are the landscapes? Each community has nuances, right? There are specific to their communities that need to be taken into account as care delivery models are being built. And so data is very core to our institution, both data and care management. Those two things working strongly in concert to really inform our practice and to really inform our engagement strategies at the Coalition. And so when we think about our mission and vision, it's a pretty aggressive mission and vision to spark the field and the movement around the field of complex care, to really be able to treat, manage, and work with individuals who oftentimes fall through the cracks of multiple systems, who oftentimes just find themselves going from place to place to place, not getting their needs met in a really consistent manner. And unfortunately, oftentimes as provider, social worker myself, sometimes we get overwhelmed, with patients as they continue to come back to our doors. And what do we sometimes do? We sometimes point at the patient and say, you need to do this, right? You need to make sure you go here at this time. You need to fill out this form. You need to get directions. So, it could be overwhelming to a degree. But unfortunately, we don't oftentimes look at ourselves as a system and hold ourselves accountable for the level of care that we either provide or in some cases do not provide. And so while we're asking people to change, right, at the individual level to do things differently in their lives, as a system, we too need to think about what are we doing differently to meet the needs of people. And so traditionally in healthcare, even in social service, you have swim lanes of work, right? And these swim lanes are basically silos. right? We're doing our work in our lane. We're meeting this particular grant. We're doing the deeds of this particular funder. We're billing at this. This is our swim lane, right? And so we're doing all our work without really not being aware of what's happening outside of the walls of our institution, or even in our community. And so with that, then, when we think about the needs of our patients, right, going from place to place to place, we need to engage partners differently. We need to collaborate differently. Data is huge right now, right? And so in our system, or locally in our region, Epic, I'm not sure, okay, I see some heads nodding. So we
heads
work,
and I
yeah, all at the same time.
It's like having
Yeah, exactly. So we work between 3 different health systems in Camden. And really, Camden is only about 9 square miles, so not that big at all. But 3 health systems that compete for the same market share. And you would think sometimes they believe that patients just have strict allegiance to their institutions, but it's just not the case. As from an outside perspective, we look at the data and we just see patients, 9 o'clock at this institution, 11 o'clock, 12 o'clock lunch here, dinner here at this, and it just kind of, work around. And so how do systems start to coordinate differently, right? How do systems start to work together differently in order to better meet the needs of the individuals that are being worked with? And so we're a 501c3 nonprofit in Camden, and again, we're a nonprofit in healthcare, and we really play as a coordinating body, a convening body. And so we like to call ourselves Switzerland in many respects. And so, our hospitals, again, are competing for the same market share. They have open lawsuits right now. One just actually bought another like a month ago. So it's a weird place. But when they come to the Camden Coalition, they know to take their institutional hat off. And we're going to look at this from the patient perspective. And that's what's going to be priority as we make decisions. And so all of them sit on our board. Their membership organizations, as well as community-based organizations and others as well.
Thanks, Vic. So I'm going to jump into a little bit of the work. And at the Coalition, we're working locally, regionally, and nationally to really define what complex care is. And ultimately, we're trying to transform what care delivery looks like in that space. And as we all know, sitting in this room, that's not an easy task. And we're envisioning complex care delivery to really encompass these 5 right here. So patient-centered care, being driven by data, right? Team-based, interdisciplinary teams, equitable, and cross-sector. So incorporating all these things into care delivery. So I'm going to jump in, and I know Victor was giving high level of the Coalition and our mission and vision, which is a little aggressive, right? Like Victor said, but we're proud of that, and we think we're accomplishing and chiseling away at it. But I want to jump into this idea of complex care and let you guys see what we're doing in Camden with our core model. So our Camden core model is our flagship intervention. It's probably what I think Victor and I would say is what we're most well known for. And what the core model is a community-based intervention, like I said before in the opening, of a multidisciplinary team of nurses, community health workers, and social workers who are indeed working with the most complex medically and most complex social patients in the city of Camden. And this work really starts upstream at patient identification. And we have someone right now in Camden sitting at a desk who is triaging patients via our HIE, which is a health information exchange, where those 3 hospitals that Victor was speaking about are all communicating through the health information exchange. And we're getting a feed every morning who is letting us know who is in the ED and who is indeed in inpatient admission right now. And our triage specialist is looking at all those electronic medical records. And they are, remember the slide Victor showed of the hotspot, that towel, there's that 1% of people that are kind of hanging out there that are the most complex. That's who our triage specialist is running towards. So we're running towards the patient that most people are running away from, right? The patients that are getting fired from practices, the patients that are labeled non-compliant, the patients that are living with addiction and unmanaged mental health and comorbidities and polypharmacy and experiencing homelessness, right? And everybody in between. That's who we're defining as the folks that are not really getting what they need out of the systems that are in place. In turn, complex care. So we're running towards these complex patients. And once we identify these patients, that list is given over to our engagement specialists who go to the hospital and meet the patients at the bedside. And there's many things that are happening at that point, but one of them is they're building the foundation of an authentic healing relationship with the patient that we at the Coalition think is critical into our engagement and interaction and getting a patient to a higher quality of life and connected to other resources. It all starts with that relationship. And in addition to that bedside engagement, the engagement specialist is talking to the patient about their goals and their priorities and what it is that they want to work on in their life. What are the things that they find important for them to have a higher quality of life, to be healthy, to stay out of the hospital, and get plugged into community existing resources. And that's what we consider the start of our care plan. And after that happens, once the patient is discharged from the hospital, that activates our community-based team. And what's happening there is the community-based team is meeting the patient wherever the patient wants us to meet them. So that may be a home visit in a patient's home, that may be in a shelter, it may be on the street corner, at McDonald's, at the public library. Wherever that patient feels comfortable, that's where the community-based team will go. And what they're doing there is they're continuing to build that authentic healing relationship. They're continuing to work through the care plan, that care plan meeting, continuing that conversation about the goals and priorities that it is that this patient wants to work on with the team. They're also doing things like medication reconciliations. They're accompanying the patients to primary care visits, to specialty visits, to social service visits, whether it's court, the Board of Social Services to navigate getting benefits, the Department of Motor Vehicles to obtain an ID. Whatever it may be, the team is there to accompany and help build the skills up for this patient to navigate these complex systems. And all the while, we're working towards graduation, meaning we're getting to a space where we're saying, okay, this patient has accomplished the goals that they have identified in the very beginning. They're to a place of empowerment where when we step out of the picture, they have the skills to navigate these systems, and or they're plugged into community resources, and we move on our way. So I want to go back to care planning for a second. So you want to take a look at this slide. There's 16 domains there. And what you may be noticing as you're reading through those domains is that a lot of them are non-medical. Right? I'm sure that's no shock or surprise to you guys in the room. When you're working with patients living with complex medical situations, oftentimes there's a lot of complex social situations. What we were finding in our work was that if you don't address these social complexities, it's really hard to move the dial with the patients, right? I see some head shaking. So we're talking about things like legal, food insecurity, transportation, right, housing, benefits and entitlements, all of these things that typically aren't being looked at in the medical picture in the EMR. Typically things we're not having conversations about, but are really impacting what's happening with the patient. So this is in turn how we actually drive care planning. So this is how our team is generating conversations with patients to identify what it is they want to work on out of these 16 buckets, and that's how we move through the intervention with the patient. So the style that we use to interact and engage with patients is a framework called COACH. And we built COACH at the Camden Coalition because early on in our work, what we were noticing was our community-based team was doing a really great job engaging the patients and interacting with the patients, and the patients were doing very well when our team was with them, right? And kind of holding their hand and doing for and finding the solutions. But what we noticed was as soon as the patient graduated, or we thought the patient was at a place where they could graduate, and we stepped out of the picture, exactly, I see you guys going like that, right?
Yeah.
The patient went right back
Very
to where they were, right? And for multiple, reasons were happening. The team was feeling very stressed out and, burnt out and frustrated about this. We were saying, like, Jesus, our work is effective here. We're doing a really good job in the moment with the patient, but what are we really doing for the patient, setting them up for the long run? So that really made us think about how we're interacting and engaging with patients. And that was when we started to build the COACH model, which is 5 foundational behaviors that our frontline caregivers use to interact, engage with patients, and continue to build that authentic healing relationship. But most importantly, what the COACH framework is doing is getting our caregivers out of the fix-it framework, meaning they're not carrying all the weight on their shoulders to fix the issues for the patient or to find the solutions for the patients and do it. Right? They're really flipping it to, a coaching relationship where we're setting up the patient with the skills and empowering them to navigate these systems. So once we're out of the picture, they can continue to do that on their own, or they're plugged in somewhere that's more long-term that can help them continue to do that.
And I think, this framework is particularly difficult for, me, social worker, nurses. You've been told that as a professional, we need to fix problems.
That's why I'm sure
right?
business are in the room.
Exactly. We
right?
need to fix issues. We need to identify root cause, and we need to systematically, boom, 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 work towards a solution. And oftentimes we think that it's going to take place in a very linear way. But as you know, when you start to engage people, we're messy, right? For all different types of reasons. And so, as Renee mentioned, when you're coming up against this, as providers, we can become very frustrated, right? Overwhelmed, even burnt out. Setting boundaries can be very difficult, right? You start to come close to that line of boundary crosses. And so even as frontline providers, how do you negotiate what am I to do, right? What is my responsibility versus what is the patient's responsibility in meeting goal X, Y, or Z? And so I think this strategy here was really a savior for us as we kind of thought about, our intervention, its effectiveness, its stickiness, its glue. How do we help patients to kind of maintain their level of health even after they've been graduated from the program?
Yeah, and another thing I just want to add about this coach framework, you can see on the bottom here where it talks about core tenets of care. The three that I like to highlight here, so it's these 5 foundational behaviors, right, that team is using when they're working with the patient. But we're also coaches infused with harm reduction, motivational interviewing, and I think one of the really important pieces is trauma-informed care. And we take a universal trauma-informed approach, just like universal precautions of washing our hands, right, to spread germs. We are taking universal precautions when we're interacting with our patients, and not just our patients, our colleagues and each other and community partners in that trauma-informed care lens, which I also think is a critical piece when you're working with patients with complex medical and social needs. So in addition to the core model that I briefly talked about, there are other arms at the Camden Coalition of work with us. So we have a Housing First initiative, where we are housing folks who are experiencing homelessness with dignity and providing permanent housing that's not in that traditional linear pattern where it's like, graduated if you're doing well and you're staying sober, you can graduate to this program, and if you do that, then you can graduate here. Hopefully housing will open up. We're kind of bypassing that and going right into permanent housing. We're seeing when we do that, we can really help the patient get a handle on other things that are happening in their lives. We also are working with folks who are incarcerated. So for the Camden Core model, we're talking about meeting the patient at the bedside for the point of engagement. But in this model, we're meeting the patient in jail, or the person in jail, and we're having our conversations there, and we're working with them once they get out into the community. What I want to focus on here is the connection to primary care. And I know that might be important to some folks in the room, but the relationships that we're building with primary care and the importance of getting the patient back and connected to primary care in a timely manner, how effective that is. I'll toss it over to Victor to talk more about that.
Yeah. And what I'll also add is that, 10 years ago, we kind of started in our Camden Core model, but these other programs are a recognition, again, that patients live outside of strictly health, right? And so, as Renee mentioned, we have a program where we're engaging individuals actually in our local county jail. 2 weeks ago, we started a program in partnership with one of our local shelters where we're now engaging individuals at the shelter. Because we recognize, that individuals who are frequently utilizing our local health systems are going back and forth between shelters, and sometimes, things get lost in between, right? And so if I'm homeless, if I'm going to the shelter, I can't make it to, roll call at 7 if I'm in a hospital bed at one of the local hospitals, and then my bed is terminated, and then when I'm discharged, right? And so, again, that communication, how do we help better coordinate at a systems level? And so as much as our work is rooted in that patient-centered experience, it's also rooted in how do we elevate our learnings to inform system-level decisions, right, at a policy level. And so, it's data, care management, and then we have a legal advocacy arm as well, because we believe that, it's through these micro-learnings that we're able to better inform practice at a higher level, so that ultimately, the system can be changed. We can get past pointing the finger at people to do things different. And so, as Renee mentioned, one of our programs that we developed maybe about 5 years ago, 4 or 5 years ago, was our 7-day pledge model. And really it was working in close partnership with primary care. And so it was a charge for our primary care practices to get patients within their institutions within 7 days post-discharge, right? And so our primary care landscape in Camden, we have huge FQHC, integrated care to mom and pop's primary care, seeing about 30 folks a day at most with little to no resources. And so huge across the spectrum. And so in our minds, we thought along with the primary care community, how can we engage, with the initiative that could span across the community that all partners felt like, they could be a part of, they could, achieve goals. It can really help to kind of build community morale. And so we did that by way of our 7-day pledge. And we actually have providers like raise their right hand and pledge and sign the document. And so we have signatures of all of our providers in the community from all the practices saying we pledge to get, folks who go to the hospital in within 7 days post-discharge. And we also had a very active community advisory council that was actually like calling primary care facilities. And like when they didn't get in 7 days post-discharge, like they would like give them like the riot, like which I'm sure helped the cause. And so, if you can start to align your forces in that way, patient level advocacy, I definitely encourage that because that also moves mountains. And so again, that was a charge for primary care to get individuals within their institution 7 days post-discharge. And we actually saw a needle move. We actually had an article in JAMA Network maybe back in February, March, that showed reduction in inpatient stays when individuals were able to connect to primary care or post-discharge from being in the hospital. And so that was on the data outcomes end, but there was also a story about how do you align community partners around a common initiative, right? And so some of you might be aware of the collective impact model, right? And that backbone organization, and how do you serve as a backbone convening body to help systems move who oftentimes don't have priorities that are aligned and their agendas might not be the same, but how do you operate in that space? And so at the end of this in resources, I have the actual article. There's actually briefings on like the how. So oftentimes we read like, these different studies, it's just these were the results and it's left kind of empty. Start like how did this even come to be? But we designed briefings about the how because that's important. How did it get here? It just didn't happen by happenstance. But individuals, communities need to learn. So that could be shared as well. But this is one of our, biggest highlights. And really, when we think about even our care management team, is how do they work in partnership with primary care, right? Oftentimes, what we've seen in our community is that primary care, they feel limited, and that their resources only extend to the front doors of their institution, right? I only see this person once they hit my door and hit this workflow, and then we engage. It's kind of reactive versus being proactive. And so our community-based team is a part of primary care's proactive response to individuals who are frequently using these systems. And so we have a lot of different strategies that we use to engage our FQHCs from scorecard meetings. We're meeting routinely with practices, going through data, right? Who are the individuals at your particular practice who are frequently using the partnering health system? How do we strategically work together to engage this person? Are they actually connected to primary care? What we saw in one of our ED pilots was that individuals were actually strongly connected to primary care, but when they went to primary care, they actually saw 3 to 4 different providers within a primary care, which led to very siloed treatment. And so we originally thought our hypothesis was that individuals wasn't connected to primary care. It's like the majority actually work. So again, how do we start to think differently at a system level to better inform our practice?
Can I just add something there about the impact of relationship with primary care and the community-based team? Is that the community-based team is giving a perspective and a glimpse to the primary care docs and nurses and schedulers and frontline, whoever, anybody in the primary care. They're giving them a glimpse into what is actually happening in this patient's life outside of sitting in this room for my 15-minute or 20-minute visit. So our team was communicating to primary care staff about, living environments, social barriers, what they're seeing when they're in the home or what they're seeing when they're in the shelter, what our conversations look and sound like when we have an hour to talk to folks every week compared to this 20-minute visit that the doc has in that real fast-paced, environment. So I think that connection and that relationship building from that perspective was really critical to allow primary care to have a different perspective of what is really going on with Mr. Smith, and he's always going to the hospital in, DKA, but there's a whole nother level of life over here that our team is able to share.
Yes, shoot.
So how does that translate into actions by the clinician? If you could just elaborate on that.
Yeah, so that's a great question. So oftentimes it looks like our staff, our nurses and community health workers and social workers and the clinician talking about that and then making, like Victor saying, a proactive plan, saying, Doc, what are the things that we can do out in the community that would be beneficial for you, for this patient, and vice versa. We're saying, Doc, this is what we're seeing out in the community. On the next visit, can you maybe lead a conversation that looks like this, or can we kind of have a conversation together from this perspective? So in turn, we actually begin to care plan in a shared, collaborative manner, where we might be asking each other to do things from this different perspective.
And what's the context of those conversations? When do those conversations take place?
So we have structured conversations that happen monthly. They're called monthly scorecard meetings, where we talk about data, but we also have time carved out to discuss shared patients. But then within this relationship building also comes that ad hoc, hey, send an email, pick up the phone, drop in and say, I was at Mr. Smith's house today and things are really bad. Like he has no electricity, he's going to get kicked out because he hasn't paid rent. So there's formal and informal, but the formal structure has enabled us to have the informal.
And then we also, through our health information exchange, we have communication built in with that, so we can send text messages, emails, obviously, so it's really that formal arrangements and meetings that really allow us to have an informal relationship with providers. But as providers, like, time is precious, right? And so when you get in those meetings, it's like you want to have a very tight agenda, and you need them to know what to expect, what do you need, even preparation, right? These are all things that we give a lot of attention to. So when we're in front of providers, we can maximize our time, and we feel like their time is valuable as well.
Just to follow up on this, sorry, I think it's such an important issue. So did your program begin with that structure, or did you sort of have to come to that later?
We figured that out a little bit later down the road.
And so how did you, I think that's a challenge that primary care practices that are engaging in other types of outreach really struggle to achieve. We have in our program here and others I know have partnerships with community-based organizations and others that are doing that outreach, but I think part of what is we haven't yet mastered is getting to that point where you're really sort of achieving that team-based ideal, and you carve out that time.
Yeah, so that was a good transition for us. Again, thinking about 10 years ago, we were kind of laser focused on our work, and we were in our own little bubble. In our clinical redesign, that's what we call this department. Those folks, that was a recognition that we need to engage providers. We need to be just as intentional with that as we are working with people. And so even starting to foster those relationships, to understand their priorities, to understand their pain points, what is going on in the practices even outside of our community-based model. What resources do we have outside of our program that we can also provide to that institution so that they feel like they're getting some value. what are your priorities? They might not be our priorities, but can we use our data resources to support your priorities so you feel like you're getting something out of that relationship as well.
Yeah.
And so this doesn't take place overnight, just like things with people don't take place overnight. This is a lot of sweat, tears, long nights, strange nights, long
Many
conversations,
years.
of work. But you can get there, and it's possible. Any other questions or thoughts? I'm totally okay with derailment. So again, a lot of our effort at the coalition is focused on level, right? So level of care. So at the individual level, how do we use data to inform our practice? As Renee made reference to, our coach model is a way really that we get data on the patient, right? So we understand the patient level needs, what is priority for that individual. How do we use data at the institutional level, right? And so we talked about how to engage primary care, using data to really better inform their practice in a way that they operate. But also using data at the systems level. And so oftentimes as providers, we dig in here and we kind of bury our head and we don't really sometimes lift our head up to see, at the institutional level or even at the systems level, what can be done to kind of operate and do things differently. And so again, a lot of our effort is focused at a systems level and doing things differently there. And so along with our patients, we work with them to advocate on behalf of their needs at a county level, or the state level, and even at the national level. And so even maybe 2 weeks ago, one of our patients was in DC talking about housing first, homelessness, and was talking about how treatment should be delivered, right, from the patient's personal perspective. Right? And now he's going to actually be giving feedback on a policy that's going to be recommended. And so we really like to hold up and amplify the voices of the people that we work with. And, this can become a very touchy subject. We think about tokenism and people's value and how do we really make sure that we're engaging people that dignifies them. But in concert with this, we actually spend a lot of time building individual skills. And so oftentimes as we're convening, we say, we need patients at the table to help us make decisions. And all of that sounds great and well, but if that person is at the table and they don't feel comfortable opening their mouth or actually advocating for themselves or their community, then it's all for nothing. It's all a waste. And so how do we even build up individual skills within our patients so that they can advocate, not just on behalf of their own needs, but even on behalf of their community needs. And that's actually, going back to our domains, one of the bubbles, advocacy. And so that's actually a priority that our patients can identify, and we can systematically work towards that together. And so again, we advocate at the local level, at the state level in New Jersey, and even on a national level. We have a national consumers group through our National Center for Complex Health and Social Needs. And so, again, that's really our advocacy at the national level. And so what we've learned is that, while we're doing our work in Camden, there's a lot of bright spots across the country of groups such as yourself who are doing a lot of great work. And so how do we start to unite and connect these groups so that we're learning as a collective, right? We can learn our own little strategies in our own communities, but as a whole, how do we better inform our entire practice as we are all engaging individuals with complex health and social needs? And so in the year 2016, we launched the National Center for Complex Health and Social Needs. We actually have our fourth annual conference coming up in Memphis, Tennessee, November 13th to 15th. And so all are invited to come, participate. And really it's a hodgepodge of just different individuals. And so we have providers, MCOs, data scientists, community-based organizations, faith-based organizations, patients, right? Like anybody and everybody is there. Foundations with the goal of how do we operate and do things differently at the systems level. So our first conference was in Philadelphia 4 years ago. It was about 300 individuals. The second was in Los Angeles. It was about 450. The third last year was in Chicago. It was about 656. And we're expecting 700, almost 800. So again, it is. I leave that conference every year feeling energized and on a plane ride. I'm just like jamming on my laptop, like things I need to do, people I need to meet, and it really helps you just to build your community and to build your network. As important as it is for individuals to build their networks and support systems, as professionals, as providers, it's equally important for us to continue to build our network and our support systems.
It fuels your fire to stay
Yeah.
in this space that oftentimes is difficult to sit in. You know, it's invigorating to go back to our mission and vision to continue to spark the field and the movement of what we're trying to do.
Yeah. And so these are just some of the institutions that we've worked with, across the country, helping out to population health strategies, at the population level, or even just patient engagement strategies. There was actually an article in Health Affairs. This is September. Still in September. This month, September, that came out that features some of our work with Regional One in Tennessee. One of our staff members, Mara Hart, who's a nurse, led that initiative. And so, if you go through that article, it actually lay out some of our strategies and how we approach folks at the system level, and it help them kind of work through patient engagement, and it shows some significant reductions in ED and inpatient utilization there. So you're encouraged to look at that model. Providence, actually, Renee and I were just there 2 weeks ago in Pasco, Washington, clear across the end of the country, and leading trainings on coach and relate. And so again, those patient engagement strategies inform people's practice at the individual level, so that they can provide better, more holistic care. And so we work with everyone from huge health system to federally qualified health centers to CBO to government to building community collaboratives to populations. So it just varies in terms of the gamut. But again, there are a lot of great individuals doing a lot of great work across the country. And that's the save the date for the conference. And the hospital, that's going to feature Regional One. That's the hospital where Elvis passed away. I visited and they're very excited about it. So I'm happy to share that with you.
And when you walk in the lobby, there's
Yeah, you
Elvis.
walk in the lobby and it's like Elvis is featured. So they were excited about that, so I just thought I would share. But yeah, so feel free to join us. These are some resources. I think this is actually a resource that came out recently featuring our Camden Core model. It shows the graduation of the model from year one back in 2011 to date. And so it walks you through phases of where we were at, what was happening in the health system, what was happening at the national level, how did we react, how we adapt our model. And so it's a very good piece to read. This is the Health Affairs article that is made reference to. Last week, we just rolled out the MAT toolkit. The opioid use is at the top of minds for many. And so this actual toolkit here, it walks FQHCs around how do you integrate that care into your practice. There's a lot of practice transformation and redesign that needs to take place at the policy level, the provider level, and even in terms of how you engage patients. And so that's a wonderful toolkit that I encourage folks to look at if you're interested. And then this is just the 7-day pledge article that I made reference to earlier in our discussion in the Chamber Network. And so we're big about resources. We're big about open network. And so always feel free to go to our website and just look at what's there. These are resources that we've built over the years, but even resources that we just kind of gathered along the way. We like to cast a big net and pull everything that we can in just to better inform our practice and the field's practice. And so feel free to reach out to me personally, or always go to our website for more about the latest and greatest. And to that, I say thank you. That was like maybe one clap.
Oh, there's like a slow clap.
Sure, question.
Yeah, so you mentioned that one of the features of your core model is giving patients the tools to succeed after graduation from the program. Is that, do you have any outcomes on how that plays out?
Yeah, so what I will say about that model is that a lot of our work is based in that warm handoff. And so it's, whether the patient themselves can meet that need or how do we find or identify support that can meet that need. So it's not always the responsibility of the patient to work themselves. In terms of outcomes, a few years ago, through our CMMI grant, we released outcomes for this model. And maybe back in 2015, there was work that we did with United Healthcare around their specific cohort that showed a reduction in ED and patient utilization. We actually have an RCT that's coming out in November that will dig deeper into utilization habits, and there will be eye-opening to the field of complex care. And so I look forward to that soon. We are embargoed, so I can't say too much about it.
You have to kill them.
Yeah. No, seriously. But what I will say is that, many of the things that we've learned along the way are important as we think about the patients that we are working with. It's not easy. It's not simply solved by, technology. It's not simply solved by a data platform. It's not simply solved by working with the patient one-to-one. There are a conglomerate of different things, skills, resources that are needed, tools, in order to really move the dial with these groups. A lot of folks are talking about outcomes, and while it's good to talk about those things, honestly, I don't know if we know enough. When we think about care delivery models such as nurse-family partnership, or even the housing first models, these are models that took 30 to 40 years to design before they became evidence-based. And so, when we think about where we are in the field of complex care, we're like infants, embryos, in many respects, still trying to understand what does it take to work with someone who has behavioral health, mental health, housing instability, like all of these factors that traditionally we haven't even wrapped our heads around. And so I say it to say we have a lot of work to do to really figure this out. I think we've made progress in that we know or better understand how to engage people, but that's not enough. There's a lot of work that needs to be done that we look forward to continuing to try to figure out with partners like that. And so stay tuned for that data.
Comment about having trauma-informed care. What did you mean by that?
I'm sorry, she coughed at the same time.
Trauma-informed.
You're very common about trauma-informed care. What did you actually mean by that? Like, how do you practice that?
Yeah, so infusing trauma-informed care lens, right, in all of our interactions, so our multidisciplinary team, right, nurses, community health workers, social workers, how they're interacting with each other, but also with our patients. So our team is trained in that. We have conversations continually around the lens or the approach that we're taking with our patients. But getting to the root of that, it's not saying, okay, I think this person, has lived with a childhood trauma or has lived through something, traumatic, so we're going to approach them differently. It's coming from the perspective that everyone is in that bucket. And let me back up for a minute to just talk about earlier on in our work, when we thought we kind of had this figured out. We were thinking that we were going to be engaging patients and really just kind of, drill down on their disease states and provide more education and really talk to them from that lens and connect them to different places. And that was really going to take care of it. But what we found was that most of the folks that we were engaging were living with a traumatic event in childhood. And that made us dig deeper into the, ACE studies and all of that. And that really had us change our approach, that it's deeper than what we thought this was going to be, right? Our engagement is deeper than this. And we really had to adopt trauma-informed care, meaning the style that we engage patients, making sure we're creating a safe and secure environment, right? Building our authentic healing relationship goes into trauma-informed care. We have our authentic healing relationship is data-based, where we did a quantitative, qualitative research study with patients that they said our relationship with them was different because it was secure, genuine, and consistent. But keeping all of our interactions in this trauma-informed care lens, and that can mean, a ton of things, but at the surface is that our frontline care team that is working with patients is coming with that approach, meaning they don't want to re-traumatize a patient. It's their style of engaging, whether it's sitting down, how they ask questions, how do they talk to the patient, not being judgmental, not asking them, why are you doing these choices? Why are you doing behaviors that you're doing? But what has happened in your life that has got us here? Tell me more about the behaviors, because when our team is looking at the patient's behaviors from a trauma-informed lens, things start to make more sense for the team, or you're taking a different approach because now you're understanding that the behavior the patient is doing is not just to do it. There's something deeper that is underlying that. So in a broad sense, it's the team coming from that stance when they're interacting with patients, the trauma-informed care lens.
And I mean, at the root of it really is how do you create safety? How do you create an environment where people can feel anchored so that they can figure out how to move forward and make decisions. And so, to Renee's point, a lot of it is about how you engage, right? And so, if I'm working with someone, sitting like this and talking to them isn't best, right? And so, to really come down and have a conversation with people. A lot of times, as providers, we go into a room and we just boom, jump into questions. We don't necessarily always ask permission. Do you mind if I ask you about, right? So again, that's a measure of creating safety, giving that person the ability to take ownership, to say, yes, I can opt in to this conversation, right? Or I can opt out of this conversation and have that level of autonomy. And so a lot of it is about, that engagement strategy. And it makes sense on a patient level, but it's even important at a team and organizational level to operate same principles so that frontline staff really feel like it's being reinforced throughout the institution, and they themselves feel that same level of safety in their environment.
Do you find that this approach is at odds with or kind of coincides with this culture of quality metrics? Because I do love the idea, and I think part of the thing that I struggle with as a provider when I want to kind of go dive deep and talk
just
about
not time, right?
Like, one, there's not time, but also like
the
that's
metrics
not
aren't
what I'm
aligned.
being.
That's not
what
what
I'm
I'm
being
getting
judged
Yeah,
on.
You're not
exactly.
getting, that's not checking the audit, or you're not getting,
Exactly. Like, so what,
And so,
is there?
so the last comment I made about institution, right? It needs to be something that's reinforced at the institution level. And to your point, our deliverables aren't aligned with that philosophy. And so as I'm a frontline provider and you're telling me trauma-informed care and I had this hour conversation, but I know I have 30 other people to hit and I need to check the box, so at the systems or policy, like there needs to be something done different, right? And so as much as we can do our work in our own little bubbles and think that we're doing great, sometimes we are doing great, at a systems level, at the MCO managed care level, at the federal level, there needs to be conversations, and there are conversations about, the delivery model, healthcare itself, right? And the things that are important are oftentimes not the things that are billed for, right? Oftentimes the things that are billed for, there's distance between how people perceive their health and what's priority. So how do we kind of start to have conversations about merging those? And so that's a lot of our work. How do we start to make headway at a systems level so that as providers, we can have the space to have those trauma-informed conversations. But I agree with you. Like it's like even when we talk about coach, like my big skill is like we can't just talk to the front line about training. Like it's bigger than this. This has to be at it's like
It's a
leadership
culture shift.
is inviting into this. Like I'm not going to go train your front lines. Like it's not going to work. Like it's just going to push me. So you need that buy-in at the leadership level.
Have you found that in systems where there is more of a push towards population health, there's more room for that? Because I imagine if you're looking, I mean, I know we're far from that now, but potentially there's room to say that within that work, because it's about the total cost rather than.
Yeah. And it's that and who's accountable for what. So even as you look through systems, there are tiers, right? So, the provider might not be in the best position to lead that conversation, but who is in that peer that could perhaps, at a lower licensure level, facilitate that conversation or drive that healthcare. Our founder and former CEO, Dr. Brenner, he was a physician, but he oftentimes said, like, the physician should not be the one driving the healthcare conversation with individuals. That team-based care, surrounded himself with other providers, a diverse set of providers, whether that's nurses, social workers, like that's the direction, that integrated model that we need to start to go in and operate in for people to really start to make headway in terms of their health needs. And so, to your point, as people are stepping back and beginning to look at things from a population health level, is how you think about strategy, engagement at each point in the system. So it's patient level, but also there's a leadership track as well, and how do you kind of create disruption in both, where, frontline is saying, leadership, we need to do this, and leadership is like, oh, we already kind of know that, thanks for mentioning it, we can now kind of merge forces. And if you look at that health affairs article, a lot of it is just that, like starting that disruption at the front line, but also engaging leadership and thinking about their practice and their building, so on and so forth.
And what's so powerful at that point of when you have the opportunity to be flexible to start that disruption, that's another time where data plays a huge role, to use data to start to create stories that you can bring to leadership and CEOs and whoever it may be to say, hey, we are in this space of maybe changing or shifting culture, and here's data to prove to you, to show to you, this is what's happening when you engage patients in a different way. And it's amazing how powerful data can be when you put it in a story perspective to start to create culture change within your system.
Thank you.
Thank you.